30-year veteran of senior services. I started out in home and community-based services. I'm a nurse by training. My mother-in-law was a high-powered entrepreneur, the woman. She took a home care company back in the 80s from a single-site startup to 42 offices across the country and took it public when it was kind of cool to go public. Now nobody wants to go public, but it was cool then. And so I cut my teeth with the home care kind of business in mind, the complete home care, hospice, infusion therapy, skilled home health, private duty. Worked in that for about 6 or 7 years. Quickly realized that home care by itself wasn't it, right? It was a very still medical model. It was very acute and reactive. So I transitioned and I said, I got a great opportunity to run this company probably as a public company someday. But I said, it's not good enough for seniors. I was really kind of a guy that wanted to do something more and different and innovate. So I left and I said, I'm going to go start my own company. And I ended up in Silicon Valley actually doing a venture-backed startup. I raised $8.5 million to do a geriatric care management company in the 90s with a private duty underbelly, right? Because there was no payment for services then other than private pay to do innovative, sort of lifelong, holistic. I was into things like Tai Chi and yoga and, actually PACE was on my radar because I thought PACE was actually going to happen. So I thought capitation was going to bring the market along with long-term care insurance for private pay and into serving more seniors, but it just didn't happen. It got killed, right? It got killed by really kind of hospital and acute care and government pay. So once again, I was sitting there with a great company. I built it up to 5 locations across the country, had great venture back behind me, and they wanted me to scale the private duty industry and roll it up. You just talked about rolling up the private duty industry. Back in the late 90s, I was going to roll up private duty. This was before Home Instead and Visiting Angels and Care Keepers and Care Covered Crapper, every big franchise that's out there. But I wasn't really excited to do that either. So once again, I walked away from that industry. I walked away from my own company, and I went back to Minnesota where my wife wanted to raise my kid, actually. She got to choose where we were going to live. And so I started this company, Lifespark, with the idea of how do we really change it? How do we really make that pivot to that experience company? Not a care company, not a home care company, not a time and point in time or a point solution company, but really a longevity company, an experience-based company. And that's what I've been working on for the last 18 years. So I'm going to share that with you a little bit, what we're doing, and why it really is relevant for what all you guys do out there today. I come from, again, home and community, right? So I want all the home and community people to win. I don't want the acute care to win, right? So I'm sort of a home and community guy, and true. I'm agnostic to environment, if you will, so I'm not into home, or I think every place is their home, right? Where they live is where their home is. And so we run, by the way, and I'll just kind of preface that so I have some relevance, we run 37 assisted living memory care buildings in Minnesota and Wisconsin, and 3 SNFs as well. So just so I have reference to your point of view, and so I'm going to tie that together into a model that I think is a winner for the future, and really that gives you guys a chance to blow up the market and win in the market, really from the point of view of where the trust lies, which is where you work with your customers, right? All right, so that's who I am and what I'm going to rip through here with you. All right, so our company is really about sparking lives. Again, like Age Magnificently is our brand. Age Magnificently, right? Agnostic to setting, but aging magnificently is really our deal. Lifespark is really reinventing the complete senior health with a radical new approach. And that approach really is the next gen of value-based services. And it does leverage the thing that was just talked about, technology, analytics, to lower member costs, improve outcomes, and deliver magnificent lifelong experiences, right? A lot of times when people enter senior living, we get them when they're they've had some issues usually. They don't usually come to assisted living without having some sort of challenges. Independent living is different. Obviously, memory care is obviously more acute. But the idea is how do we break down those silos and create that longitudinal experience? And that's really what Lifespark's all about. So, before I tell you about what Lifespark's doing and how it really reflects how we can work together and how we're going to work together in the future and what I think the market's going to offer us, this is really the problem that we all face. This is the roller coaster of healthcare crisis. Some of you might have seen me talk about this before, but really quick, on the left axis is well-being over time. And regardless of where seniors enter in our services or your services or anybody's services, they're doing pretty good. Their life experience and physical health on the left is up there. That's where they're independent. They're doing their own thing. They're not needing services at this point. But what happens is, life happens, right? It could be a social determinant issue. They get lonely. Maybe because of COVID, they haven't seen their granddaughters and grandkids in a long time. They start to deteriorate a little bit. Maybe they stop eating, then they stop taking their medications, and then they get dizzy, and then they have this crisis, right? This hospitalization event, this on that lower end there. When that happens, that's when acute care, or that's when our medical system, what we call healthcare, right, in our vernacular, it really goes into place, right? Then because the government pays for it, right? They go into the hospital, they get their hip surgery, right? They get their 7 days in the hospital, then they go to the TCU, right? They spend 17 days in the TCU. Ironically, 17 days is what the reimbursement rate allows, about 17 to 19 days. So every client is about 17 or 19 days. If some of you that run SNFs know that what I'm talking about. Anyway, everything is all on payment, right? So then when they get up closer to that top of that next bump, then they get discharged, right? Because they've met their maximum potential, right, for rehab. And they go home with skilled home care. Skilled home care comes in. Now a new EMR, a new team, a new reimbursement model, new regulation. And home care serves them until the top of that bump. And then home care is done too, right? Because they're not medical necessity, the time's up, they rehab, and then those services go away. And by the same token, their families that have been in town serving and helping them through that transition go away as well. And maybe Bob here, give him a name, Bob's right there, that crescendo. Now, he's not where he was as baseline. So what happens to Bob is everybody thinks, oh, he averted the crisis, it's going to be okay. Well, it's not okay, because nobody dealt with the root cause of what happened and why Bob was really having the problem in the first place. So Bob falls down, maybe he gets a cold and exacerbates one of his chronic conditions. He has another slip down into that next bottoming out, where, his neighbor has to come over and find him face down on the carpet, and he goes 911, and now the thing starts all over again. So if you go back and look at all your clients, when they come on admission, right, when they come into your facilities or they come in as a new resident, 95% of people are going to have some version of this roller coaster that they've been on for a little while, right? Because obviously they're coming there mostly after some sort of challenges in their life. But after 2 or 3 of these, obviously things start to really change, and their hope goes away, a lot of their independence goes away, and that's not what a real health system should provide for our seniors, right? So this is, if you will, the problem. This is the protagonist and to our story here. And so I just wanted to share it with how a lot of seniors go through this. Why it happens really quick is reimbursement. We pay for acute reactive care in America. Let me just say that again. We pay for acute reactive care in America. That's what our taxpayer dollars cover, acute reactive care. When we reward something like that, acute reactive care, what are we going to get more of? Acute reactive care, right? It's rhetorical. That's what we got. So that's where all the money goes, right? That's where the 20% GDP, the $4.1 trillion, most of it goes there. Because most of the clients that are paying out of pocket for all the things that you guys are providing, right? This is the government dollar, right? So reimbursement's wrong, right? Because we don't pay for prevention or proactive, right? We don't pay for housing, other than a few little places. The other part is oversight. Again, socioeconomics drives a lot of this, because 50 or 60 years ago, who used to care for mom or dad when they got infirmed or elderly or older, right? The adult daughter, right? The adult daughter of the children. Where are all the adult daughters today? They're all right here, right? They're all working, right? And so they're geographically spread, too. They're all over the country. So you think about the socioeconomics, and I don't want to spend too much time on this, but it's a big deal. Geographic spread, more women in the workforce, less family people, less family available, right? But then the other thing is fragmentation. We fragmented the crap out of our experience for seniors, right? Because everybody builds point solutions, everybody builds a place in time, right? Home care, private duty home care, skilled home care, senior living, obviously skilled nursing facilities. Everybody has their point in the game. Acute care, primary care, subspecialty care. Everybody's got a place, but we've chopped up this client in so many pieces that there's not any really integration across it. So that's a really big deal. And like I said, payment, integration, fragmentation, and oversight, right? There's nobody that's really there. That's really the primary care world has changed from family practice. For those of you that are a little older, we used to have family practice in America, where you'd go and they would know you. Now we moved to primary care, where we have about 19 minutes on average a year with our primary care physician, right? And when you're a senior with polychronic conditions, how do you manage that? And then we took one more step further even, and we went to subspecialty. Everybody has subspecialists, right? All your clients, they have a rheumatologist, an oncologist, a cardiologist, all these ologists, right? And so that's created, this big problem. So what we want to do is flatten that out, right? Flatten that out through integration of services, flatten that out through the experience, the trust, the relationship. And so Lifespark as a whole, we've done a lot of these services. Like many of you have more of a portfolio than just one product. We have a lot of products. We have everything from transportation to home health to skilled home health to hospice. We actually added primary care. We have housing. We've had a lot of these things. And so that's great. We had a lot of pieces and parts, so we're trying to do it in the worlds of reimbursement that were afforded to us, but that wasn't good enough, right? That wasn't good enough because there was still too much slippage and too much fragmentation, to a point where we are now, and what's happening, and this is where I really want to spend the time and share with you what's important for you all, is that population well-being is here to stay. Everybody's been talking about triple aim. If you've heard this in healthcare, triple aim, it's been kind of a triple miss to this point, where people haven't really integrated value-based opportunities for seniors across their lifetime, right? And this offers an opportunity of quadrupling where you have better health, better experience, lower cost, and joy of work, right? Everybody likes to say that and talks about that, but there isn't really a model that's demonstrated that kind of value before in global risk or value-based pay. I know that well, let me just keep going here. So here's really the point, right? This is the pivot point for my talk today, really, is that thinking differently to access all available funds, right? So out of pocket is where independent living, assisted living, memory care, that's where it lives, mostly, right? Agreed? That's where the money comes from, out of pocket. Lots of out-of-pocket dollars. That's not, when you think of a client, they have two sides of a wallet, right? If you think of your consumer, right? They have their out-of-pocket dollars that they've saved for to pay for these types of services, and then they have their earned benefits, Medicare and Medicaid. But no one has really snapped the two together. No one's brought both the resource buckets together to deliver a more complete experience. Does that make sense? So that's what we're talking about here, is how do you get access to those earned benefit dollars? And what I'm here to do is tell you how to do that, right? I want you to get access to the earned benefit. There was mention of PACE. PACE is an old model that's tried to get there, but it's not robust enough. It wasn't well timed. It was ahead of its time. But now with the ACA, the Affordable Care Act, Obamacare, and now all these new ideas with Medicare Advantage and payment reform, it's time, right? This is unlike any time in history is now to get access to these earned benefits in your ecosystems, right? So how do you do that? How does that work, right? So when you look at a building, right? So you look at one of your housing environments, let's just use a 100 resident community, right? Right now, when you break that down into who are these people and what are their reimbursement side other than their private pay, who's really there? And so out of 100 residents, you have about 5 to 15 ISNP members. And this, many of you have probably been sold on, Ally Line, or many of you are working with sort of an ISNP product, right? Because it's the first emerging part of the ecosystem that's coming to you, right? Because they're seeing where you have these sick, polychronic populations in your environments, and they want access to them. So you're bringing an ISNP opportunity. It's a little easier, it's a little cleaner, but it's only about 5 or 15% of the total population in your building. So what does that leave for the rest of the building? What does that leave for the rest of the residents to get access to this earned benefits? There's 30 or 40 that are Medicare Advantage members, right? So you don't track that probably. Many of you don't even look at that. You don't even know that. Some maybe you do, right? But there are 30 or 40 that are on a Medicare Advantage plan through a payer. It could be a national payer like Humana or Aetna or Blue Cross, or it could be a local payer in your state. But they're there, and they're on risk. They're on a risk contract. Then you have 40 or 50 Medicare only. They're just Medicare Original, so they've done nothing. They still have Medicare. They haven't bought a Medicare Advantage. But the government, a few years ago, created this thing called direct contracting entity. It's DCE. Some of you, has anybody heard of DCE in here? Some of you? Not many. Okay, so really quick, Medicare said, look, payment for seniors is out of control. We need a new solution. We need to start letting other people take risk for these populations. And so they created the opportunity to let providers, primary care physician groups, other groups, to actually take risk for Medicare Original. And so this is emerging, brand new. This is in the last couple of years, where they said, if you want to take risk on Medicare populations and go at global risk for these folks, you can. Go ahead, because we can't keep spending the money that we're doing. We need smarter, better solutions. So you have 40 or 50 of those in your building, and then you have 0 to 15 duals, right? Dual eligible populations. Probably not in the private pay world, because these are Medicaid eligible populations. But some of you do, because you have subsidized waiver programs in your state. Some of your buildings have waiver. So the point is, there is a value-based product. There is money that is right there now for all of you to have access to put aside with each of these clients of their private pay dollars to deliver something completely different. That's really the big deal. That's the big news, and that's what everybody's chasing in the market right now at the national level. There's a lot of companies coming out. I know they were just talking about the investment community. There's a company that recently. Has anybody heard of Landmark? Right, a primary care company. There's Landmark, Iora, ChenMed, Oak Street, Dispatch, Concerto. All these companies that I just named are all raising not just millions, but Landmark just sold to UHC last year for $4 billion, and they had a revenue of about $120 million. So do the math on that. What kind of valuation? They're valuing companies that can access these global risks, these value-based opportunities, and deliver full spectrum services to these folks, right? Wherever they are. Can be home, can be in assisted living, can be in independent living, doesn't matter. Somebody's got to get a handle on the total cost. And when I say total cost, I mean hospital stays, acute care, inpatient, outpatient, specialty, subspecialty, home care, right? All of it. All of it. Anything that Medicare A covers is what we're talking about here. When I say global risk, anything that Medicare covers is global risk. And so if you're willing to take risk on that, you can play ball and get access to those dollars today. All right? So there's a value-based product. So what we do at Lifespark, and what you need to do this, right? So you say, well, okay, Joel, that's great, but how do we do this, right? How does this really work? How can we have access to those dollars? You can't really go it alone right now, right? You need some partners probably, right, in your markets. But it's not that complicated. There's a few pieces that you really need. For Lifespark and how we do this, we call it Lifespark Complete. It's global risk. We have big technology. We have a really deep technology arsenal because we obviously have to really understand what's going on from a proactive, preventive, predictive standpoint. So we have to really know this resident, what their needs are, what their wants are, what their life plan issues are, as well as what's going on with them medically, right? What's going on with their claims history, what's going on with their medical conditions in a macro way. So electronic, we call it an electronic life record, not another medical record. We have a lot of medical records. We have 5 different businesses, so we have Point Good Care, Home Care, Home Base, and Matrix Care. We have all those EMRs, but we aggregate them into this electronic life record. So aggregation and interoperability is here, right? Technology, as we talked about, is here to stay. And so this is a way to get it done with this electronic life record. But you need technology and a technology platform because you don't want to go at risk without having good data and good analytics. But then you need geriatric medicine. This isn't hard. Each market has different independent physician groups. There's different groups out there that you can work with. We have our own at Lifespark. We have our own medical practice. But, this is something, again, that you can broker and partner with. And then the other side of it is this life management. Again, these are like geriatric care managers. Many of you have, in your organization, you have a role like this or something like this. This is a little deeper. Works with the family and the client. But, again, it's really this SDoH and life management. These are RNs or OTs that we use for this role. So having the geriatric medicine, the RN, or OT on the relationship side with the family equals, kind of this population well-being with technology. So that's what we've created at Lifespark to have access to those government dollars and take those contracts at risk. This is a little bit more detailed on that complete solution. You need life management, you need geriatric medicine, like I said, you need quality, you need coding, because a lot of this gets complicated. This is why people shy away from it. Some of you maybe have never even heard of a RAF score, but RAF is how the clients, how much revenue has attributed to each of them in this government side. That's important. Integrated technology, as I said, analytics, activation, how do you get them enrolled and activated, and then a high-performance network, right? So that's that. Everything and anything to keep them in the best possible health so they can be in the best possible life experience that we all want for them, right? So this is kind of, again, more of the Lifespark sort of solution, but the components that each of you would need to be able to deploy to get access to these populations. So what does participation look like? Engage in the care model, best practices. What we're doing with actually we have our own 37 buildings, but we're working with a lot of other senior housing in our market. We work with probably 7 different large multi-location senior livings in Minnesota, right now. So we're working with a lot of them. So we're not competitive, even though you say, well, you're senior housing, we're senior housing, we're competing for the same people. And we're like, no, we're not worried about that. We're not trying to grow our senior living, even though we have 37 buildings. We're trying to grow our experience, and so work with us to get access to these government dollars, and let's win together. So that's what Lifespark's doing now. So we have probably, on top of the 37, we probably have another over 110 10 that we've identified that are working with us to really roll up this whole strategy from home and community and win, right? Win big, really big. So that's what we're doing. So the participation with the other entities that we're working with, right? What would you need to do if we came in to work with you in our ecosystem? Although you can do this, again, with others. It doesn't have to be Lifespark. But engagement in the care model best practices, right? What does that mean? Those are a lot of things that you're doing already with activities and coordination and care coordination. Some of that social determinant work, identification and activation, right? To get them on the right product at the right time. Preferred partner relationships, bi-directional data. So it's not just for us. It's not just sucking data in, but it's pushing back data to the users, to the people at the front line, so they understand these customers differently and more holistically, and what's really driving the economics. And then, in this case, Lifespark's the first call. So, as you guys know, Friday night, when somebody has a slip or fall, right, you have to call 911, and then they get admitted, right? For us, no one gets admitted, right? We send out an APP, an advanced practice nurse or a physician at real time, 24/7. I should say no one. Sometimes they do, but very infrequently, right? We are staving off all that inpatient stay, because that's really where the big money is, right? Is in inpatient stay. You have to avoid acute care. And when you do, the dollars are massive, right? You're talking about $30,000 for a hospital admit. Just imagine all the hospital admits that come out of your buildings every week, right? I mean, people are going to the hospital, right? They can be $30,000 to $60,000. You know, it can be runaway trains. And what if you could take that money and put that into the resident's experience, right, in your own building? What if you could put that into the brand that you guys are building, right? That's what this is all about. So this is what participation looks like. For us, when we've done this together, when we've deployed this geriatric medicine, this life management, this technology, right? This is what's driving, real value. 43% likely to have inpatient admissions. And this is on thousands of clients, right? This is on thousands of data points. We have 24% less likely to have visit the emergency department with our clients. And our net promoter score is 93. So these are just a couple. I mean, we have tons and tons of data around these populations that's showing us, finally, after 30 years from me doing this work, that this is the right way to go, right? It's fully validated. It's fully efficacious in the work. And by the way, just to put this in context, so Lifespark, what we've done is we've created global risk contracts with our payers in the market, so we actually take full risk on about 10,000 lives now in Minnesota. So 10,000 lives equals about over $100 million of medical spend that Lifespark's taken risk on to basically put that back into the customer's experience and journey. So this is real, right? I just want to make sure you understand it's real. So what does it mean for all of you, and kind of what is this economic opportunity starting to emerge and look like for all of you out there right now? This is the big money slide, right? So I can tell you, with our buildings, our 37, we're achieving between 5 and 8% NOI improvement right now, right? How is that possible? What are we doing? So it really is in two areas, right? So if you look at the left-hand side right now in assisted living, lower revenue, lower occupancy, days lost service revenue, increased expenses, obviously with labor and everything, right, with the Great Resignation, we all know labor, and all the issues with, staffing sucks or whatever, staffing companies suck. Like the monitor, everybody gets that, right? So that's hard, because labor is hard and client acquisition is hard, so it kind of equals a lower NOI right now. And so if you look at, with Lifespark Assisted Living, because of that value-based model, that value-based revenue, millions of dollars, quite frankly, that we're actually having access to, or risk on, you could put it. We're having higher revenue, higher increased lengths of stay, and we're a magnet for new customers to start with on the revenue side, right? So what do I mean increased length of stay? So imagine your clients not having to go into inpatient stays, right? You know what happens when they get in the hospital, right? They get delirium, they end up with a nosocomial infection, they may or may not even come back to you. Plus you're losing your revenue on lost time. So just from a couple standpoints on the increase on the length of stay, plus you're having clients that are living longer, living healthier, right? That's all matters. So that's a big deal. Magnet for new customers, because of this integration, by able to offer this brand, this offering to families to say, hey, look, you can have everything right here. You don't have to go into the hospital. We have geriatricians that are experts here that work with you on your primary care. It's all right here at the building. It's all right in this community. I mean, that's a pretty powerful proposition. And so we have a magnet for new customers. In fact, in our markets right now in Minnesota, our mature coming out of COVID, our occupancy was about 82, 83 for our buildings, kind of across all that portfolio. The employees that work inside these buildings are loving it, right? Because now they feel the energy around not having their clients have to be degraded into inpatient stays and kind of get hammered with the different things. They have real geriatricians and people working with them to create a real interdisciplinary team, a real interdisciplinary opportunity, and they're seeing the additional advancements and investments that we're able to make in the client's experience, but also the employee experience. So we're actually not using a bunch of staffing and all that sort of stuff. We're actually hiring. We hired 700 people in the last 6 months. 700 full-time people in the last 6 months. So improved culture. Our reduced client acquisition is also really big in the decreased expenses. You all know how important it is. A lot of these clients are coming sicker right now to you, right? As you can see, a lot of them are coming more sick and more complex, right? And so the reduced client acquisition happens because they're not going to higher levels of care. They're aging in place, right? Even at this independent side, where if you want them in the independent, we're keeping a lot of people in the lower levels of care by surrounding them with some of these other services under the global risk. So that right there, for those two higher revenue and decreased expenses, we're seeing about 5 to 10% of NOI in our buildings. So I'm not just talking to you here like, oh, we can have 5 or 10% NOI. No, this is really what's happening. All of our, if we got into the details, you'd see our economics, and I'd be happy to share. But then the next final thing here is this new value-based revenue, right? This is where what Lifespark has done and what we want to do is share in that risk, right? Share in that full revenue opportunity on the Medicare Advantage, on the duals, on the Medicare Original through ACO REACH. And so this is where we're working with our partners to have access with us, kind of alongside on that risk. So we're seeing that as a 5% opportunity, upside downside for you. So you guys have the trust in your buildings. You guys have the most valuable thing, the relationship. And so that's really cool. Plus you don't get to harvest the value that you create. You might be saying, well, I want to incorporate this new technology because it's great for fall prevention, right? But it costs me money as an owner. And I don't get anything for it. Like, I'm not getting paid to keep people out of the hospital, right? I'm not getting paid for my innovation because I'm not harvesting any of the value. So, right? So it's hard to innovate because you don't have a motivation to get reimbursed for good outcomes, right? Your outcomes really don't mean anything, right, to the market and for you, right? Even though you're doing it. So this gives you that opportunity to say, look, we're good. We're good at this. We're good at keeping people aging in place. We're good at really making value and creating value and avoiding catastrophic failure in the acute care side. So why don't we get some of that money, right? So we can put it back into the buildings, put it back into our opportunities. And that's where that new revenue is, and that's what we're going to market with. Lifespark's just getting ready to scale nationally, and so we're offering this exact proposition with almost, we're willing to put some even guarantees on some of this as we work with some of our senior living partners because we're so confident in it, right, over the last couple years of experience. Which equals, again, that higher NOI. So you guys get that, I think, and that's really the money slide of what I wanted to share with you today is it's a better path forward. It's probably the first opportunity ever that's ever been available with the trends that are happening to be able to make a real pivot and change the industry and change it for the better. Because obviously it helps the workforce, it helps the employees, it helps our economics, and it transforms and starts to break down the walls, really, if you will, and lets us really get out into the communities in a different way as well through these opportunities of aggregating with our brand. So that's what I wanted to share with you today. So I think I'm about up here. I have one thing that I wanted to share with you as far as the experience, and then I might have time for a couple questions quick. But this is something I wanted to share as far as what does this really look like for seniors, and I wanted to share a story. Obviously, it's always great to share a story, but this is a production that we did trying to tell the story from the standpoint of somebody that's not all sick and broken down, but it's not really thriving, and we call it our going south video, right? Because when you hear the word going south, a lot of people say, oh, you get old, you break a hip, you end up in a nursing home, and you die, right? That whole going south story about aging, and this is one more of hope. And so, can you cue that up for me quick?
Mom, can I get you some water? No, thanks, honey.
Yeah, I'm just really worried about Mom. It just feels like she's heading south.
Hi. Sarah from Lifespark.
Oh, it's so good to meet you in person. Come on in.
Thank you.
This is Marjorie, my mom.
Hi, Marjorie. I'm Sarah. How are you today?
Hurts.
Is it any better than it was yesterday?
No.
How's your medication treating you?
Woozy.
Little woozy. That happens sometimes. So you play cribbage, huh? We're just gonna start the call. There we are. Good morning, doctor.
Hello, Marjorie. Great to see you.
Little better postured. Do you cook anything these days? You want to play something?
No, thank you. Not today.
Marjorie, this is quite the collection.
Oh, yes.
Let's see, if you had no limitations, where would you go?
Oh, I'd see my grandkids.
They're trying some new things. Well, she seems a bit better. That's all it is?
That's all it is.
All right, and we'll do one more. Great.
Hey, Michael.
Hey, how are you?
I'm great.
Looks like your physical therapy is doing really well.
Not doing any backflips yet.
Give it a little time, Marjorie. Looking good there, Marjorie.
Thanks, Ken. 15, 2, 4, and 6.
My.
At 81 years old, my mom, Marjorie Rose Bennett, did head south.
Look at these shows.
Oh my gosh, look at these. They're wonderful. Where did you find them?
The beach.
Oh, well, you better show me. Come on.
And that was just the beginning.
Great, so that's Marjorie. So I just wanted to share Marjorie, and I wanted to thank you all for the opportunity to share with you sort of the next revelation of opportunity in the market, where there's a new economic engine for this to happen, for this experience to happen. So thank you for letting me share that with you today. We're going to do a master class, I guess, a little bit later.